Thank you so much, Dr. Joshi, for taking the time out today to talk about mental health and the causes and types of mental health conditions in today's world. Before we begin with the clinical stuff, can you tell the audience a little bit about your background?
Yeah, I'm a psychiatrist. I came to the United States about 45 years ago, and I trained at Johns Hopkins. I initially did a year of medicine, then 4 years of psychiatry, and then a year of neurology. And then I'm board certified in neurology and psychiatry. And I've been in private practice of psychiatry since 1980. So it's been about 45 years now.
Wow. And Dr. Joshi, just to start with the basics, what is mental health? What are the most common types of mental health conditions? Like, for example, anxiety, depression. Could you talk a little bit about these? And what is the percentage of adults you see in your office that come in with these kind of issues?
Just to give you a little background, we have 10 clinicians here, and we see about 250 patients a day in
Wow.
this practice. Yearly we see about 40,000 patient contacts. So it's a large number. We're the largest prescribing psychiatric practice. Most of what we do is medication management and treatment of mental health conditions from a medical model.
Okay.
Essentially, the commonest thing that we see today is anxiety. And we, of course, see some bipolar disorder, some dementia, some patients with delirium, some other conditions, but 67% of our patients seen here have some form of an anxiety disorder. So anxiety disorders are probably the commonest that what we see here.
And is anxiety like a chemical in your brain, like which causes it, or is it stress related or genetics? Like what causes it?
Anxiety. Let me first talk a little bit about anxiety itself. Anxiety itself is like an umbrella. It encompasses multiple conditions that fall under anxiety disorders. So one condition would be what we would call an adjustment disorder with anxiety. So for example, if you have a life crisis and you're anxious about it. The other one is called generalized anxiety. This is the common we see most commonly. This is a condition that is anxiety going on for over 6 months, disruptive in your life, causing trouble in your day-to-day functioning, and of course leading to substance abuse and other stuff. The third anxiety disorder is panic disorder, which is an extension of anxiety disorder. The fourth one is obsessive compulsive disorder. The other one is post-traumatic stress disorder. These are all, and eating disorders also. These are somewhat extensions of anxiety disorder. But in general, so that is what the overall anxiety disorders are. In terms of percentages of people, in a year, 20% of people in this country, adults, have anxiety of some form or the other. And over a lifetime, usually a third of people, 1 out of 3 people in the country, will suffer from an anxiety disorder. Now, whether they get it or not is another matter, but that's how common it is, almost a third. So 20% at 1 year would have anxiety, and 1/3 over their lifetime will have anxiety. And of course, out of this, there'll be a small percentage for generalized anxiety, small percentage for panic disorder, small percentage for obsessive compulsive disorder. So this is the overall part of anxiety. In answer to your question about where anxiety comes from, nobody quite 100% knows because it's always nature nurture. Nature is the genetics and nurture is the upbringing. We call it nature nurture. So from a biological point of view, we find that many people with anxiety have either some kind of genetic factor or a family history of anxiety, and family history is very common, and that's the genetic piece of it. The other part is sometimes MRI shows some particular abnormalities for people with anxiety. Sometimes some parts of the dorsal amygdaloid nucleus, which is a part of the brain, shows in some people with anxiety an increased response to frightening events. So this is the biological piece of it. The environmental parts of it are traumatic childhood experiences, trauma, abuse, and of course, substance abuse one way or the other can also, that's the nurture part of it. So it's really both. So some people have preponderance of one, some of the other, meaning some more biological, some more circumstantial. But it's largely the genetic factor.
And do you think anxiety leads to depression?
Yes.
Or it's the other way around?
I don't know. In our experience, I find that in women where anxiety is more common, anxiety occurs first. And then over time, it leads to depression, understandably so,
Yeah.
because it causes a disruption in life, problems with relationships, and withdrawal, isolation, and those kinds of things. So it leads to depression.
Are women more prone to being anxious than men?
Yes. I don't know if they're more prone. I think they're a little bit more prone hormonally, but I think they present with anxiety more often because they come to get help more often. Men probably don't get,
Yeah.
stubborn, obstinate, and headstrong as they are,
Yeah.
and they're the machos. So they don't usually come with depression. Instead of they're too wimpy to say that they're anxiety. Women have a little more anxiety than men.
And is that related to hormonal issues?
Yeah, I think part of it is hormonal because definitely hormone swings in women, whether it's premenstrually or whether it's premenopausally, cause all these changes which have, and these are steroids, these hormones are steroids, progesterone, estrogen. So I think with women it's more common in general.
So, Dr. Joshi, when should a person go to a psychiatrist? Like, what is that alarm that goes on in a person's body, or a family member sees the person suffering, and then it's time to go to a psychiatrist? Because I feel like this is a subject that's been taboo, especially in developing countries like
Right.
India,
Right.
South Asia, and there are not many mental health institutions
You're
there.
absolutely right. And we remember family members that were isolated and remained in the background because of the anxiety and never were able to get help because there was no help available. It was
Sure.
also taboo. And where would they go to?
Yeah.
There were no, the only places in India in the 70s and 80s were in New Delhi and Bombay and Hyderabad and other places, but 90% of the country did not have any
Yeah.
in Asian countries. I think the question is, when do you seek help? I think the first thing to do would be to probably go to your primary care physician because the first thing to look at is there anything medically related? Okay, thyroid disease, low blood sugar, some substance abuse issues, or problems with your parathyroid gland, endocrine issues, and even hormonal imbalances. So I think the first thing is to probably start with a primary care physician to rule out anything physiological underlying. And I think at that point, I think the primary care physician, I think many primary care physicians are pretty trained to treat people, at least initially, and then they seek some help from psychiatry.
So once, Dr. Joshi, I did my blood test and my vitamin D was low, B12 was low, and my primary care asked me, "Are you depressed?" Because these are low.
Yeah.
Is there some connection between vitamin D, B12 with depression?
I think there can always be some connection that people will find, but I think it's far beyond that.
Okay.
Okay, so I think those are just small red herrings that sometimes are used. They don't cause depression. They can trigger depression. They can make it worse. They can extenuate it. But I don't think these thyroid disease can cause depression. Low thyroid can cause depression.
And how is that, if you don't mind explaining the science behind it a little bit?
Yeah, thyroid is a gland in the neck, and the thyroid gland is actually the metabolic gland of the body.
Okay.
So what it does is it releases a thyroid hormone that drives the metabolism of the body. So it drives the heart, it drives the lungs, it drives the body, it drives the breathing mechanisms. It also drives mood states, so that all of these states get slowed down. So people with low thyroid become overweight, they become exhausted, fatigued, they get tired more often, they have a low heart rate, and they get depressed. So it's a complete metabolic syndrome.
Wow. So keeping thyroid in check is very important.
Yes,
for
thyroid in
mental
check
health.
is important. And of course, while you're doing a medical workup, it's also important to, would be to also check if there's any substance abuse going on in the background. Is there any alcohol in the background? Because that in itself is the other way around too. I mean, not only can anxiety and depression lead you to substance abuse, but substance abuse can also enhance depression and cause anxiety. Because if you're drinking one day and not drinking the other, and you're having alcohol withdrawal, that also causes anxiety. So I think a primary care physician should not only do a good medical workup, but should also inquire about any substance abuse or alcohol. And also, I think a primary care person should investigate if there is any abuse going on in the family, or is there any trauma going on? Is there any major stresses? Because that's the nurture part of the part that can enhance anxiety.
So more of a holistic evaluation
Right.
rather than just blood work.
So I think the first thing would be to go to a primary care physician.
Okay.
And I think these primary care physicians need to be actually educated on at what point they should refer people, because there's not enough psychiatry available, even in this country.
But Dr. Joshi, some primary cares send you to a therapist first, and some send you to a psychiatrist. And for someone like me who has no idea about this world, it's very confusing because you open up your insurance and you see, oh, this is a nurse practitioner, this is a psychiatrist, this is some other medical professional in this field, but you don't know who is the right person to give you the medicine. So if you could just explain that difference and who should one start with?
Yeah, I think start with primary care and sort of figure out how good your primary care is. And I think if the primary care is open to treatment, is understanding, is questioning you well, and has some experience with psychiatric medicines, sometimes starting off from there is not a bad idea. The only problem is that primary cares they start the medicines, but they don't know what to do with it next. They don't know the dosages, they don't know what to do and where to go. So I think that depends on primary care. We find that about a third of primary cares are superbly trained and do as good a job as a good psychiatrist. A third of primary cares are totally out in the left field. And another third are like it's a hit and miss. So it's hard to say. And then on top of that, you have now nurse practitioners practicing medicine. And it's the same thing with them. So it's very hard.
Yeah, I mean, it's taken me around 9 years or 8 years to find a good primary care doctor in United States. So I agree with what you're saying.
So let alone finding a primary care, next step is even
harder.
Even harder, because where do you go? So the way I tell people to go is my own family members to go would be to, if you know somebody who knows somebody who has gone to somebody, those are probably the best ways of figuring out. Okay, by looking at these insurance handbooks and by looking at these names, you don't know what the heck you're getting.
Sure. So you go to your primary care. Would your primary care send you to a psychiatrist, a therapist?
Yeah. So I think the primary care should make a decision if the symptoms are mild to moderate and the anxiety and the primary care feels comfortable in managing medications, then I think the primary care should start them off with some medications. And then the primary care should also investigate a little bit about the person's life circumstances, what's going on, how they're coping, how they're integrating in their family system, what's going on with their children. And if they feel that there is some discordance there or some dysfunction there, then they should refer them to a therapist. But that's finding a therapist is even worse.
Difficult, yes.
Okay, you have no idea. Even therapists don't know what they do to some degree, because you have cognitive behavioral therapists, you have supportive therapists, you have marriage therapists, you have psychoanalysts. Of course, those are somewhat a thing of the past now today. But I think starting off with some medication and then perhaps being referred for some brief short-term counseling, it doesn't hurt. And then I think sometimes I find that these therapists, you're referred to a therapist sees you for a few times, gives you support. And if the therapist has a good relationship with the psychiatrist, they make a quick referral. Sometimes they make better referrals than some of these primary cares, because these therapists are linked up with some psychiatric practices where they know that they can get good care.
So, Dr. Joshi, there's anxiety which happens once in a while. And then there's anxiety that happens every day or once in 2-3 days. How do you know that this is actually a problem and this is just not a once in a while thing? Like, is it when it goes on for 6 months, 3 months, 1 month?
So the way that most psychiatrists delineate this, that anxiety that comes off and on and lasts a few days at a time would probably go under what is called adjustment disorder with anxiety. That's a mild condition, and that does not necessarily require medication treatment. But if the anxiety has been continual for over 6 months, has caused symptoms that disrupt your life and are accompanied sometimes by panic attacks and sometimes with OCD-like symptoms and others, they need to be treated.
Okay. And is anxiety also related to being, I wouldn't say delusional, but when you start getting these fears that, someone's going to die or something wrong's going to happen, or, it's just like a lot of fear, which makes the anxiety even worse.
Right.
So is this like a different kind of mental health issue?
No, that is anxiety itself, but it's
Okay.
almost prepondering on panic. It's like microscopic episodes of panic.
Okay.
But they're really an extension of anxiety. And when these are happening, they require treatment because then they're being really disruptive.
They require treatment.
Yeah, they require treatment.
Okay. And a lot of people, through this phase where they end up doing some kind of substance abuse, whether it's alcohol, drugs, or even medicine. Do you think anxiety and substance abuse is related?
It's related both ways. People with anxiety are at much higher risk for substance abuse and alcoholism. And then people with substance abuse and alcoholism also sometimes can get withdrawal and can get anxiety and depression. In men, usually, we find that they probably have anxieties to begin with,
Yeah.
but then use more substances, more alcohol abuse, more substance abuse, which suppresses the anxiety, but then causes depression and dysfunction in the long run. So that's why I was saying that with men, we find more depression rather than anxiety because it's submerged a little bit more with alcoholism and substance abuse.
So, an untreated mental health condition, which, like anxiety,
Right.
could lead to substance abuse, which would make
Bring-
your anxiety worse.
Exactly, because when you're drinking more, you're not drinking, you're having alcohol withdrawal, you're having more anxiety, it's disrupting your life, it's causing more and more. Then it becomes both nature, nurture, and explosion.
And Dr. Joshi, apart from medication, and I'm going to get into medication a little more in detail after this, what are the other kind of therapies that are available for people?
So, anxiety studies have shown that anxiety can be treated with medications, but in the long run, anxiety can also be helped largely by cognitive behavioral therapy. Because if you think about it, these cognitions that make you look at something, you think of something that makes you anxious, that makes you more anxious, these need to be recognized, and a therapist needs to have you understand them and build some coping mechanisms. So it's almost like sometimes we give examples to people when you're anxious. Put a rubber band on your hand and just zip yourself with the rubber band. It just breaks the cycle. Okay,
Wow.
so or sometimes
Like any kind of rubber band?
yeah, I just tell people to you can put a color one if you like, colorful one, or a decorative one if you
And
like.
just like snap it.
And just snap it. It just breaks the cycle sometimes of these anxieties. Sometimes counting to 100 or counting sheep or counting or getting into a different mode. Instead of the anxious phenomenon, you're replacing it with something else. These are all cognitive behavioral techniques and maneuvers that help people in the long run. And also, I think working with life issues, coping mechanisms, and letting people understand that some of this will get better and will pass, and it's not the end of the world, even though it's easier said than done. The way I explain to people is I tell them that with anxiety, that medications get the car started, but therapy teaches you how to drive the car. Okay, in a similar, medications for anxiety help in early phases, but in the long run, you also need cognitive behavioral therapy to help you.
So, now that we're focusing on one type of mental health issue, like,
Right.
say, anxiety and depression, things like social media, teens getting anxiety because they're too much on social media, or adults, for example, getting depressed because they're losing their jobs. Are these situations contributing to anxiety, depression, like in the long term? Do you feel it's like a slow poison?
I think these people probably have some degree of anxieties to begin with.
Okay.
And on top of that, it's just adding on. It's like an add on. It's not a causative factor. So when people say it's causing this, that's not essentially true because not everybody on social media, there are people who can control themselves. There are people
Sure.
who can. So I think it's more of a contributing factor rather than a causative factor.
Okay, but losing a job does make you
Of
depressed.
course.
Going back to, like, having stress and environmental issues in your
Yes.
life which cause
Yeah,
the
so those are
anxiety.
called reactive depressions, and those usually last a few weeks. And usually people rally around it, recover, come up with a game plan, and think about it. But people with what we call major depressions, which is also a chemical imbalance kind of thing, it's linked to anxiety, but it's uh, if it lasts for more than 4 weeks, then that becomes a depression that also may need treatment.
And Dr. Joshi, I want to really focus on this one type of depression, which is postpartum depression. It's because I'm a mother. I myself have been through postpartum, and I feel like this is something that is not known and goes untreated, and most women don't know anything about it. So if you could talk a little bit about what it is,
Yeah.
when do you know it's an issue, and how is it different from baby blues?
So, postpartum depression is something that we are evolving in our learning over the years, and some recent things have come, which I'll talk about later. But the way we divide it, uh, uh, just postpartum blues is anything that lasts less than 2 weeks. Okay, postpartum, and then passes. So that's postpartum blues. Any severity that lasts more than that, if it occurs in the peripartum area, that's called peripartum depression.
Yeah.
But postpartum depression, by definition, is a depression that occurs either during pregnancy or postpartum. It's not just postpartum, even though it's called postpartum. Postpartum depression includes depression during pregnancy. 50% of, well, how common is it? 1 out of 10 women will suffer from postpartum depression that requires treatment.
So this is not something that every woman goes through.
No. Most women will go through the postpartum blues or the 2 to 3 week cycle. Okay. But 1 out of 10 will go through what is called the postpartum depression, which in women, half of the time it occurs during pregnancy, and the other 50% occurs postpartum. And in postpartum time, the first 4 weeks after delivery are the worst. That time, it's about 54% comes then. 40% occurs between the first month, second month to the sixth month.
Okay.
And then 4% occurs till 12 months. So it can last as long as 12 months.
Wow.
It's not just, sometimes some people think postpartum is like 2 months, 3
Yeah.
months. It actually lasts longer. It can last all the way up to 12 months.
Wow.
So that is postpartum
Depression.
But this is different from the postpartum blues. Okay?
Yeah.
Postpartum depression is a syndrome where there are classic symptoms of what we call major depression. Depression, sadness, lack of interest and joy in day-to-day activities, feelings of hopelessness, helplessness, having trouble concentrating, thinking they're a useless person, they're a hopeless person, and all of a sudden it's like everything becomes negative. It's like a cloud over the person's head. Along with that comes often, not often, but most often, you can get almost paranoid symptoms where you think that people are talking about you, or your mother-in-law, or your mother is talking about you, or your husband is out to get you, or that while you're doing all these dramas of delivering, the husband is out there flirting. I mean, those are horrible, almost psychotic things that happen.
Yeah.
And then there are sometimes thoughts of wishing the child would be dead.
Yeah, I've read about that.
And occurs quite common. And
Yeah.
it's almost like, and that brings them immediately help. It's almost a psychotic phenomenon.
Yeah.
They know they don't want to do it, but they feel like they could crush the baby's head, or the baby's head looks like revolvable. Okay, I'm making it sound frivolous, but actually it's extremely serious.
Yeah.
It's almost like you feel like you might kill the baby, or hurt the baby, or squeeze the baby's neck, and you get weird thoughts about the baby. You look at the baby and you say, what object is this? So it's just a psychotic kind of phenomenon. This is postpartum depression, and it's fairly severe. It can lead to suicide. It can lead to the person running away. It is probably one of the worst. And it's interesting that it occurs more commonly in people who have had anxieties before. It occurs more commonly in people where there's a family history of postpartum depression. So women with previous episodes of depression, women with previous history of anxiety, women with a family history of depression and anxiety, some history of trauma, they need to be carefully watched. And they need to be educated about this might occur postpartum so they can talk about it and get the help they need.
So, I mean, this is a pretty serious thing, but what goes on in the brain, like chemically, what goes on that you're saying and thinking things like?
Yeah, nobody 100% knows what goes on in the brain, but the belief is there's something called the catecholamine hypothesis, which means that there is some neurochemical deficiency. Some people really believe there is a serotonin, norepinephrine transporter genes. Basically, the bottom line is there's some chemical imbalance in the brain, which affects the mood thermostat of the brain that throws it out of gear. Okay, but with these people, there's some problem with the serotonin and norepinephrine chemicals that affects them that way, and sometimes it's linked to hormones, where the mood thermostat doesn't work properly, and everything begins to look dark, turn dark. It's almost like a normal person would be looking at sunlight, but these people have a cloud that comes over their head. It's a chemical imbalance.
And are there any medications to treat this? To,
Yeah,
be ahead of the game and just start taking medication before delivery?
I think if someone has had a family history of depression, if someone has been treated for depression before, if someone has had an anxiety disorder before, if someone does not have too many support systems and others, and then perhaps starting them postpartum on medications is not a bad idea. Okay, these people, but not everybody. Others should be watched. If the symptoms occur, then they should be treated.
And what are the kinds of medications?
So in the past, we used to basically use the same medications that I use for anxiety and depression,
Okay.
which are the SSRIs, which are Prozac, Zoloft, Paxil, Lexapro, those kinds. Essentially Zoloft was the one commonly used, but all the SSRIs can be used.
And these don't harm the baby.
They don't harm the baby. We usually keep people on them through pregnancy, and then
Okay.
postpartum sometimes we increase the dose a little bit.
So no harm to the baby while the baby is inside or on breast milk at
None of
all.
these. Yeah.
Okay, that's good
But
to know.
again, prophylactically should only be used when there are all these extenuating factors, not to anybody.
And have you seen a change in people who take these medicines? Do you feel like it helps everyone, or there's certain people who these medications don't work on?
These medicines work in most people. About two-thirds of people they work on. In a third that they don't work on, some people get better with support and other stuff. Some people get better by themselves. And of course, there is a risk of suicide with these conditions also. So they need to be carefully watched.
Okay, so these are the only medications available.
Now, these are the medications that were available till 2 years ago, 3 years ago. Recently, there is a group of medications which are very interesting that are progesterone derivatives. So the first medicine that came out was called zuranolone. Okay. It's a medication that is a progesterone metabolite, and it was one of the earlier medicines was given intravenously. So these people had to be in a hospital for 60 hours. They're given an IV medications for severe postpartum depression, but those were it's hard to be available for these things. It can only be given in a hospital setting. But now there is a medicine called zuranolone available that is a progesterone metabolite. So that is much more of a sort of hormonal flavor. So that has been approved by the FDA in 2023. We are just starting to use it now, but we haven't gathered much experience with it. We still would use an SSRI.
Like a Zoloft?
Yeah, because we're more familiar with it. It works for most of our patients, and we're able to manage them. Now, sometimes patients may require, if they're having severe depression, and along with the anxiety and depression, they're having some psychotic thoughts. Remember that we're talking of killing and those kinds of things. Sometimes we use some antipsychotic medications briefly, like Risperdal and others.
What do these antipsychotic medications do to the brain?
The antipsychotic medications are actually, in a simple level, they treat psychotic symptoms. So psychotic symptoms are delusions and false beliefs and hallucinations. They rarely occur. They sometimes can occur in postpartum depression, and the psychotic medications help that. In the past, we used to call them neuroleptics, and we used to also call them major tranquilizers in my time when I was training. Now we call them antipsychotics, but they sort of block the dopamine and help with the psychotic symptoms. And they can be used briefly with postpartum, what we call psychosis with the depression.
Wow. And schizophrenia and bipolar would be psychotic depression, right?
Well, they're not depression more,
Yeah.
they're completely different conditions.
Okay.
Briefly, schizophrenia is a condition where there is a dopaminergic. Dopamine is a hormone, a chemical transmitter in the brain. There is a increase in dopamine in certain parts of the brain,
Okay.
and it causes schizophrenia. Schizophrenia is one where you have psychotic symptoms, and these people um, can also have some cognitive changes over time. They can deteriorate also. This is the classic schizophrenia. It occurs in about 1% of population. In the past, they used to be treated mostly in state hospitals, like mental hospitals, and they were chronically there because there was nothing available. But in the 50s and others now, a lot of antipsychotic medicines have come that help the psychotic symptoms. So these people can get better help today.
I've never really understood the difference between schizophrenia and bipolar.
Yeah, they're two different conditions. Schizophrenia is a condition where they have hallucinations and delusions,
Okay.
and they require antipsychotic medications. Bipolar disorder is a condition which causes, there are two kinds of bipolar disorders. One is called bipolar 1, one is called bipolar 2. Bipolar 1 is a condition in which a person can have manic episodes, which can last more than several weeks.
Okay.
And manic episodes are when they're ecstatic, talking too much, think they're on top of the world, can't sleep, get agitated, get into trouble, spend money, are sexually impulsive, and they are manic, grandiose. That's the mania. So, and then following that, they can have depressive symptoms of the same kind that we talked about before with anxiety and depression.
Wow. So there's different medication for schizophrenia, bipolar.
Schizophrenia, we use antipsychotic medications. Bipolar disorder, we use medicines like lithium, lamictal, Depakote.
And these seem like more severe mental health issues. They can't be treated with CBT at all.
These essentially are treated with medications, but of course, supportive psychotherapy is helpful.
And do you think, Dr. Joshi, changing your choices like lifestyle choices, food choices make a difference in your mental health?
I think they do. I think, not everything is just as simple as biology.
Yes.
And, perhaps as psychiatrists, we look at largely biological stuff. But honestly, again, like I said before, medications get the car started. Therapy helps guide the car and learn how to drive the car. So
Okay.
I think if you look at all these illnesses in this parameter, I think medications help the biology, the functioning. But they don't quite 100% fix the problem. Okay, some of the results that have occurred because of this illnesses require counseling, guidance, support, a kick in the butt, and all those kinds of things
Yeah.
that require help.
And do you think it's okay for someone who has mild to medium depression to be on the Zoloft or Wellbutrin all their life?
Yeah, we usually have some criteria we use. If someone has one episode of depression and anxiety that has only lasted 6-8 months or so, we usually like to, at least in our practice, we like to keep them on the medicine for 12 months. And then the next summer or early spring, we don't like to take off meds in the winter.
Or is it weather related?
We don't know what it is, nobody knows.
Yeah.
But there's some belief that winter times are worse for these. So we like to tell people to get off the meds only in the spring.
Wow.
Okay. So that we can better watch them, the longer days, and that there's a better observation for them also. I don't know whether that's entirely true, but there is a seasonal component to some of these ailments. So one episode of depression, anxiety, or bipolarity, or any of these, schizophrenia needs lifelong treatment.
Okay.
But everything else, usually one episode, we like to keep people on meds for 12 months. If someone has had more than one episode, then it's a choice for 3 to 5 years or a lifetime. Okay. Then we look at it like having a blood pressure problem.
Okay.
Taking blood pressure medicine. Why would you get off it?
There's no harm in taking it lifelong, right? There's no like hair loss or say weight gain or some other side
I mean, there are
effect.
some minor side effects that occur with everybody, and some people are different. Some people may have a modest weight gain, but whether the weight gain is related to weight gain or whether
Or to
the
eating, yeah.
medication, eating, we don't know. Sometimes there are some medications that can cause some sexual dysfunction, some of the SSRIs. So we reduce the dose sometimes. We keep them on the lowest possible dose. Sometimes we tell people to take a drug-free holiday before sexual intercourse. So there are lots of things available.
So when sexual dysfunction is that you're not interested in your partner?
Sexual dysfunction with medications is largely, it is more orgasmic dysfunction. Okay. Not so much a reduced wanting to have sex. So if that occurs, sometimes reducing the dose, sometimes not taking the medicine at that day and taking it after 6. Lots of little options. And sometimes adding a little bit of Wellbutrin is amazingly helpful.
Okay, so Wellbutrin is also like, it's like an antidepressant, but
Wellbutrin is an antidepressant, but it's a kick. So like I tell people that it's like a horse that Zoloft is like a leash on the horse that regulates it. The Wellbutrin is a kick in the butt. Okay, the Wellbutrin is a little bit of an activator. The Wellbutrin also helps you lose weight, helps with sexual dysfunction. So we commonly add Wellbutrin to an SSRI
got it.
to balance things.
And Dr. Joshi, this is a little out of context, but this has been on my mind for a while. ADHD. How do you know a child or an adult has ADHD? What are the most common symptoms?
So ADHD is, in my time when I was training in the 70s, we never thought that ADHD occurred in adults. We thought it was a children-related thing. We thought it occurred in boys who are hanging from, chandeliers and, fans in India,
Yeah.
and were so hyperactive that they couldn't sit still. And even those people, we just managed them by shoving them outside, making them play in the yard,
Sure.
and falling all over. But those were different days. Today's days, you can't have these boys out there, or even if your daughter has ADD.
Yes.
So today, severe ADD in young people is difficulty with, and usually it occurs, it begins very early when it occurs, but it's hard to pin because, it's a child. So 3 or 4 year old, you have to wait till they go to school. Once they go to school, if they start to have difficulty functioning, they can't sit still, and the teacher is calling you out day after day, then it requires treatment. Okay.
Okay.
So this is of a child. Symptoms are distractibility, lack of attention, some hyperactivity, not being able to sit still, looking out the window, just not being able to focus on the work, and things like that.
Okay.
But these are smart kids. ADD people traditionally are very smart. So many of them get away with it because they're cute kids, they bullshit their way out of class, their parents think they'll outgrow it.
Yeah.
Many times they even reach high school, okay, and because they're so smart, they can cram at the last minute and they can get away with it. So these are the smarties that other people would be reading every day and barely making it, and these kids at the end go to the bathroom, read, and run in, do their exams, and do well. Okay, so in children, it's unless it's very severe, it's very hard to pinpoint. Okay. In adults, this diagnosis, in one sense, is easier, one sense is harder. So in adults, we're finding a lot of adults that come here. In fact, we have out of 20 new patients calls we get a day, there are at least 5 that are asking for ADD evaluations. So in adults, ADD goes like this. 1, there's a family history. 2, you have to look back on their history and their symptoms that began before the age of 12. Okay, even though they may not have been treated because they're cute and hyper and whatever. Thirdly, the symptoms are a lack of attention, difficulty focusing. Now, some of them come to us when they've just gotten married and they're forgetting what milk to buy, or they're constantly calling the wife from the grocery store saying, "Oh, which milk did you ask? Was it the 2%?"
But isn't that every man?
No, it's not every man. It's some men with severe ADD. They're all over, and it gets worse and worse. So 1, family history; 2, before the age of 12; 3, all the symptoms; 4, now the symptoms are causing difficulty in 2 areas of your life, whether it's school, college, and family. Okay. Your marriage is breaking down because the wife has had it, or the other way around. And lastly, it should be in the absence of any other mental illness.
Okay. So anxiety, depression, and all are not related to ADD at all.
Well, they're related in the sense that people with ADD will have anxiety and depression also as a result of it, because they'll be beaten at home, they'll be getting the wrong milk, they'll be anxious all the time whether they got the right milk or not. But that's more reactive anxiety. Once you treat their ADD, their anxiety will be better. That piece of it.
So there is medication for it.
For ADD, the medications are very, very effective.
Oh, wow.
Okay. In fact, ADD meds are more effective than all the other antipsychotics or antidepressants. Classic ADD medicines work like a charm, and you have someone who's hyperactive, who's not able to sit still, is not able to have is having marital problems, they're having college problems, they're having life problems because of ADD. You give them ADD meds and they quiet down, they calm down, they start focusing, and they get much more productive.
And these medications are for children as well?
These meds are for children as well, but in children, some of these meds can have side effects. So there are some reports of bone density issues with Ritalin and others. So with children, you have to be a little bit more careful. Unless they're very severely ADD, I would do everything else in children to manage as best as you can. Unless they're being thrown out of the class, they're killing things at home, and they're causing utter chaos.
Yeah. Okay, that makes sense. And Dr. Joshi, to add things, I know this is a little controversial, and no bill has been passed yet, but if SSRIs were banned, how would that impact mental health patients?
I mean, 22% of people in this country are on these medications and are benefiting from it. So it'll cause deep distress. It'll cause a great deal of trouble. And I don't know why they be banned. People just have to get them from other countries.
So there will be major health consequences.
Of course, just like anything else, just like blood pressure meds, others. I mean, these are as important as cancer meds.
But why is there then a debate about it, like that they're not good?
Well, there is a group of anti-psychiatrists in this country. You know, Thomas Saz was one of them, and then I don't know who that actor is, Tom Cruise. Okay, I mean, these are all anti-med guys, even though their spouses were on these meds and doing well. So these are people who are fanatics. They think their own way. Okay, they think they're right. Okay, but the most normal people like us believe that these medications are helpful if used properly.
So your biggest concern if this was banned would be like the health of your patients?
Well, I think the health of our patients. I mean, just think about it. We see 40,000 patient contacts a year. We see 1,500 new patients a year. We see 250 patients a day. They're all treated. I've been seeing people for the last 42 years. I've seen every generation of these family members now. In fact, most of our referrals in this practice come not from doctors. It comes more from family members of patients who have known us.
Do you think people will start using other kinds of drugs like I think it's weed and marijuana?
All those are crazy things because all those drugs, there's evidence to show that it kills the brain, that it knocks out the brain and causes atrophy in the brain and causes all sorts of trouble. And we just get devastated by these weed shops all over this country.
Yeah, it's not.
I mean, yes, it's true that some people with severe pain, weed can be helpful to these people. Okay. But then so can narcotics to these people for pain, or so can, so you can give them anything that'll help them. I mean, severe pain should be treated, but not using weed for everything.
Sure, that makes sense. Dr. Joshi, this has been amazing. Thank you so much
for
all this amazing information that you've given us today. And I really appreciate you taking the time out and talking.
No, it's my pleasure.
Is it okay if I put the link to your website and your contact details at the bottom of the podcast if anybody wants to get an appointment or reach out for help?
No problem.
Thank you so much.
Okay.